Hi everyone. I'm Twinkle. I'm the publications chair for the Cannabis subdivision of the American Chemical Society. This is our monthly journal club, and today we have with us Dr. Ms.Sexton. Currently, she is working in the clinical cannabis kind of area at UCSD, which is in San Diego. And she graduated from Washington State with her PhD. And she's been working on endocannabinoid research for almost 20 years now, with an interest specifically in clinical chemistry, it appears. And so she started working in research at University of San Diego, or UCSD, sometime in 2016, and then was asked to join the faculty afterwards, and then was brought in to work with the clinical side of cannabis. So today she's going to be presenting their research on medicinal cannabis for migraines. And this is like a really exciting study because it's one of the first studies that I've seen where it's a placebo-based study using cannabis and actual people. So I think this is going to be really exciting. And if you guys have any questions, please feel free to put them in the chat and we will answer questions at the end. Thank you. Take it away, Dr. Sexton.
Thank you. Just as a correction, I do not have a PhD.
Sorry, the
My
ND.
Yeah, naturopathic doctor, and so I studied at Bastyr University, but I did do a postdoc at the University of Washington in the lab of Nefi Stella, where we studied roles for the endocannabinoid system in neurodegeneration and neuroinflammation. Okay,
My
so today
apologies. Thank you.
I'm gonna tell you about, excuse me, a study that we completed. And this was funding that went to Dr. Nathaniel Schuster at the University of California, San Diego. He is a neurologist and a migraine specialist who works in the pain division. And so this was something he was very interested in as a migraine doctor, and got this funding from the Migraine Foundation. So this is our publication. It will be formally published in Headache this fall, I think October. And so the title is Efficacy of Vaporized Cannabis versus Placebo for Acute Treatment of Migraine, a randomized double-blind placebo-controlled crossover trial. So we knew that there were preclinical data, retrospective analyses that were supporting the potential for treating migraine, uh, but there had never been a formal clinical trial on this topic. So this is the first one that's ever been done or published. So migraine is it's a horrible thing that pe many people are living with. Of course, it affects women predominantly. And there are migraine treatments that work for some, just like any drug, and are efficacious in the short term for some people. They can be used to treat an acute attack or for prevention. Um, but almost everyone needs these acute treatments. So, it's just like almost with any disease, if we can catch it early, so aborting a migraine early in the attack is the goal. But, there's not, it's not an optimization. Some people don't do well on the drugs. Rates of discontinuation are high. And it's really not always optimal treatment. So good, good time to look into something new. So this data, some evidence for cannabis treating migraine has been around for quite a while. This was the American Dispensatory by Harvey Wilkes Felter that was published in 1898 in its 18th edition. And under the monograph for cannabis, uh, indication included migraine, nervous headache, facial, other neuralgias, whether due to catamenial wrongs or attending the menopause, as well as those depending on fatigue, are relieved. And then noted that it was most effective when nervous depression is the most marked symptom. So, we don't know exactly what he meant by that, but we're going to talk a little bit about cortical spreading depression having a role in migraine. And then Sir William Osler wrote in his 1916 textbook, cannabis is probably the most satisfactory remedy for migraine. So Osler was a Canadian physician and a founding professor at Johns Hopkins, and he established the first medical residencies. John B. Madison was a U.S. physician, and he was kind of known for making a startling claim back in 1883 that most of the habitual users of morphine were doctors. So he had a little bit of notoriety. But about cannabis, he said it's a drug that has special value in some morbid conditions, and the intrinsic merit and safety of which entitles it to a place it once held in therapeutics. And the most important use was for treating that opprobrium of the healing art, migraine. So he concluded that cannabis not only blocks the pain, but prevents migraine attacks in agreement with Osler. So we know at that time we don't know if they were inhaling it, but that was when extracts were probably the predominant use. So this is probably things you already know already, but just wanted to review cannabinoid receptor expression, that CB1 is the most highly expressed receptor of its type across the brain in all the brain regions. Where you see the red is indicating the more dense regions, typically in the basal ganglia area. And we know all of the things that CB1 is involved in. What's missing here is that it does have a role in the immune system, and the immune system in the brain. Immune cells also express CB1 receptor. And we typically think of CB2 as being the primary one, and it does play more of a starring role in the immune system in migration of cells, phagocytosis, expression of cytokines, and cell proliferation. So why might cannabis work? We have preclinical evidence and data that suggests a bunch of mechanisms, and there doesn't have to be one mechanism. It could be all of these mechanisms working together that are bringing relief in migraine. So this is a really good review paper in the Journal of Headache Pain that was published last year, and it has some great figures. But I thought very interestingly that this red arrow means that the green means we're going to benefit migraine, and the red means maybe not, and that's the TRPV1 receptor. So this is just a representative neuron, and CGRP, which, the new drugs for migraine are CGRP blockers that tend to work pretty well for people. But then we have all these immune cells. So just kind of bringing in that the immune system and the neuroimmune reflex play is also playing a role in migraine. So, some of the mechanisms that have been thrown out there are inhibition of the trigeminovascular system. So the trigeminal nerve, it's the fifth cranial nerve. It's got 3 branches, and the vascular system involved in that we know is involved. And this could be partially due to serotonin release, mast cell degranulation. There could be direct effects on serotonin receptors from cannabinoids. Probably one of the most interesting neurologically is the inhibition of cortical spreading depression, which is thought to be playing a role in the migraine symptom of aura, which is these hallucinatory type visual effects that people get. And so this is a propagated wave of depolarizing the neurons, and this is followed by suppression of brain activity. And so interestingly, at the same time, at the beginning of this wave, there's some interneuron hyperactivity, and the SCN1A sodium channel is involved in some headache. And I'm just bringing that up because this is a mutation that occurs in the children with epilepsy or Dravet syndrome. So mutations in that channel are also associated with childhood headache as a different entity from Dravet. There's also this idea that we're going to address a purported endocannabinoid deficiency in people with migraine. So we don't really have any biomarkers of that. You know, measuring the endocannabinoids is time consuming and challenging. So we don't really know if migraineurs have lower levels of endocannabinoids, and this could be occurring in different compartments and may not ever even be reflected in the brain. But there was a study that came out pretty recently showing that inhibiting the breakdown of the two primary endocannabinoids, anandamide and 2-AG, by inhibiting MAG lipase or FAW, so thereby increasing 2-AG and anandamide levels in the brain, uh, help to suppress this cortical spreading depression. So that's a pretty interesting mechanism. So I just kind of want to go through a little bit of what's been published clinically about migraine and cannabis. So as I said, there haven't been any prospective trials. This is the first one. Here is a retrospective chart review of 121 patients who reported reduced frequency of migraine over time, reduction of use of other pharmaceuticals, lower scores on a disability assessment, and a decrease in frequency from 10 per month down to about 4. And so this was a significant finding. And in this retrospective review, participants reported using a combination of inhaled and oral forms daily, with inhalation used for acute treatment. But the only randomized controlled trial of cannabis for headache, and this was not migraine, but this was medication overuse headache, studied oral nabilone, which is a racemic mixture of a THC analog, versus ibuprofen for medication overuse headache. And it definitely favored nabilone over the ibuprofen. One other observational study of data from the Relief smartphone app showed a mean headache pain benefit decreasing by 3.3 points within 2 hours of administration. And so this again was just people accessing local cannabis and using it and reporting. And this again was not specifically migraine, but headache. There was a case series out of the UK from their medical cannabis registry, and they also saw significant improvements at 1, 3, and 6 months from using cannabis, and they were following up with people over time. However, efficacy of inhaled cannabis for acute treatment of migraine has only now been studied. So we were talking a bit earlier about the challenges of trying to do clinical research with cannabis, and it is a very frustrating and lengthy path, which I think, you know, there have been some changes that have made it a little bit easier, but just wanted to say from the time that Dr. Schuster received funding until the time that we enrolled the first subject was 2 years, which, you know, at this point, the Migraine Foundation's already thinking about taking their money back. So it was pretty stressful because, you know, you have to jump through all these hoops. There's so many federal regulations. We had to make sure we had everything in place for the Schedule I and for receiving the cannabis from the University of Mississippi, and then all the regulatory approvals through our local IRB, the FDA, and then we have a separate state research advisory panel of California, which we tried to disband this year and were unsuccessful. And then associated with that Schedule I license, all the security requirements, you know, a locked safe to keep the product in, et cetera, et cetera. And probably one of the most frustrating things of trying to do the research was sourcing the cannabis material. So, you know, of course, we can only get it from one source. And getting a response from them was challenging. It took forever to get the cannabis in stock. I mean, that was a long part of the delay. And of course, always getting funding is the first step and sometimes the most difficult step. All right, so what was the protocol? So for this study, we enrolled volunteers who had a clinical diagnosis of migraine, and they were going to be instructed to treat 4 distinct migraine attacks. Each of these attacks had to have 7 days in between them. And we were going to use a vaporization device, and each patient would be randomized by we had cannabis, and there's capsules that go into the mighty vaporizer, and our pharmacist packed capsules with either a 6% THC cannabis, a combination of CBD and THC at 6% THC and 11% CBD, and then a 12% CBD cannabis with no THC, and then their placebo cannabis. So interestingly, I never saw the product, but soon after, I think it was one of our first subjects enrolled, I got a call from our study coordinator because the person who had tried to treat their first migraine, when she inhaled off the vaporizer, inhaled a bunch of plant material. And so it turns out they have basically ground this material to a very fine powder. And the holes in these capsules, were much bigger than the particle size. But that was the only time we got that complaint, as far as I know. So our primary endpoint was to look at pain relief at 2 hours, and secondary endpoints were headache, pain freedom, and freedom from their most bothersome symptoms. So to be included in the trial, um, the inclusion criteria was being between these ages. They had to have a formal diagnosis of migraine with or without aura. Um, but we did want them to be experiencing some of the other most bothersome symptoms to be included. So nausea and or vomiting, phonophobia, and photophobia. They had to agree not to use cannabis outside of the study or to use opioids or barbiturates during participation, agree not to drive a motor vehicle because we did send them home with this cannabis. So in the past, it's basically only been given in-house where we've had study facilities for that. And then we had internally, we developed a mobile application where the patients went in and recorded that they were starting an attack, and then they were pushed notifications to fill out the surveys over a 48-hour period, but particularly we were looking within this 2-hour time frame. So again, the outcomes were pain relief. So we're looking for a reduction of pain from moderate or severe to mild or none, and also sustained pain freedom at 2 hours without return of pain or having to use rescue medication. And then these most bothersome symptoms, we were asking about those on the questionnaires, and also sustained relief from those symptoms. And then, as with all clinical trials, we had adverse events, and we were talking prior to this, like who decides what events we're asking about. And I can only say that we used a list that's been used through the Center for Medical Cannabis Research at UCSD over time. And so there are adverse events, and then there are serious adverse events. So we looked at subjective highness. They rated how high they felt. Were they sleepy? Did they have euphoria? Any cognitive impairment? Who did we not have in the study? If anybody was using cannabis outside of the study, so they had to have a negative drug test for THC, barbiturates, opioids, oxycodone, or methadone. If they're pregnant, a prisoner, current suicidality or severe depression, current or past history of other mental illnesses,
Dr. Sexton,
Uh-huh.
I'm sorry to interrupt you. It looks like I'm getting a notification that they're gonna kick us off this Zoom call in a minute. And so I just wanted to give you a heads up. I'm gonna restart it and you can just join back in. Everyone can join in using the same link if it does end abruptly.
Okay, okay.
Sorry about that.
Or any allergy to cannabis. So those were our exclusion criteria. And then we have these mighty vaporizers that were donated by Storz and Bickel. They were not involved in the design, conduct of the study, manuscript preparation, and they didn't give us any financial support other than donating the vaporizers. So they were trained in the Fulton uniform puff procedure, which is 5 seconds of inhalation, a 10-second breath hold, exhalation, and 45-second waiting period before repeating the process. And they were instructed to do 4 inhalations total. So then they took the device home with them and instructed to initiate the treatment as early as they could, when they initiated having symptoms. So they would turn on their app, say they had a migraine. They would have a list of questions that we're going to ask them. Are they having these symptoms? How are they rating them to see if this headache qualified? And they had to have had no other intervention for this particular migraine and that the migraine was not resolving on its own. So we enrolled 92 participants overall, randomized them. And so they were randomized. They just had these capsules that were labeled 1, 2, 3, and 4. And of course, everybody had what was in those capsules in a different order. So they didn't know what they were getting. If it could, placebo could have been the first one, and so on. So our median age was 41 years, as you can see, mostly female. Um, let's see. And like most studies, mostly white people, unfortunately, that tends to happen a lot. Um, the median age at onset of migraine was 20 years. Median migraines per month was 6. So we treated 247 individual migraine attacks. So that was 60% of the 92 participants completed all 4 attacks. And we only needed a sample size of 72 for 80% power. So we met our powering. So our primary efficacy outcome, like I said, was headache pain freedom at 2 hours. And so here we're looking at placebo. You could see there was even a 15% response rate to placebo, which is pretty standard for placebo. The CBD just a little bit above placebo, but not significantly different from placebo. And then we had 6% THC cannabis coming in next. But you can see that this mix that was almost a 2-to-1 of CBD to THC outperformed the others, and that this was a significantly different from placebo. So what about the secondary efficacy outcomes? We were looking at pain relief versus pain freedom and most bothersome symptom freedom. So here is the most bothersome symptoms. And again, you can see that the mixture of CBD with THC outperformed the others. So what about these adverse events? You can see the percentages at 1 hour, 39% felt sleepy, 21% felt euphoric, and 17 felt impaired. And when we had them report how high they felt, you can see that in 100 of these headache attacks, nobody reported feeling high. And then again, at 2 hours, we repeated this. Being sleepy was about the same as at 1 hour. Euphoria had decreased a little bit, as well as feelings of impairment. And again, the majority not reporting, well, now they're scoring it at a 1 instead of a 0. So there were no serious adverse events reported. So again, here are all of them that were reported. So, They're all the pretty much the same ones that you see across cannabis studies. Again, at 2 hours, we can see these numbers have dropped a little bit. We had 4 people feel very high at 1 hour, and 0 felt very high uh, at the 2 hour follow-up. So at 2 hours, more than 2 patients, sedation, impaired focus, slowness, and dizziness were the primary symptoms. But again, you can see that these were very low in incidence. And then we asked them questions, what else would you like to tell us, or what other kind of adverse effects? And this is pretty small, so I don't even know if you can read it. Um, Faster heart rate, that's a common one with cannabis. Tingling face, throat irritation, munchies. Anyway, I'm not going to read the whole list, but that is available if anybody's really interested in it. So what are the conclusions? That the 6% THC plus 11% CBD was superior to placebo for our primary outcome and our secondary outcomes. Other tertiary outcomes were freedom from photophobia and phonophobia at 2 hours, 24-hour sustained pain freedom, and 48-hour sustained most bothersome symptom freedom. So the 6% THC was superior to placebo for the primary outcome at 2 hour pain relief, but not the secondary outcomes. So limitations are that, this was only one single center study, so it's always good to have studies across geographics. We only looked at THC and CBD, not other minor cannabinoids or terpenes, because the University of Mississippi plant material has pretty much been baked until probably, I don't know if anybody's done a terpene analysis of their product. Only one dose of each treatment was studied. So we don't know if, a higher dose could be more effective, or if a lower dose could still be effective and better tolerated. And we only studied one THC to CBD ratio. And then I just wanted to illustrate that, plant product is available out there, at least here in California, not always easy to find, not always in stock. But if you follow the evidence and the research, a lot of people complain about the University of Mississippi cannabis and its very low potency. But if you look at all of the studies for uh, vaporized cannabis for either pain or multiple sclerosis spasticity, these low potencies were effective. And in one of our pain studies for diabetic neuropathy, we did a secondary analysis on THC blood levels that showed as the blood level went up, the pain benefit was actually lost. So this is the type of cannabis that I'm typically having people access for medical purposes. So you can see here's almost a 1-to-1, another one that's a 1-to-1. Here's one that's a 1 to 20, literally like 1% THC. So if we can't find a 1-to-1, I can have patients grind these and mix them to come to a 1-to-1 mixture, or a 2-to-1 if they're trying to replicate the study. And then, now we have CBG. We don't really know yet if CBG has any of the same kind of pain relieving qualities or not. So that is the end of my show. Thank you for your attention.
Thank you so much, Dr. Sexton. That's really interesting. This is a great time for questions. If people have some questions. Oh, we've got one question. Let's see. Do you think that the inclusion of other minor cannabinoids with better non-terpless material would have yielded better results? So basically, do you suspect that minor cannabinoids improve these effects?
I'm a bit of a skeptic on the minor cannabinoids personally, just because, we don't really have any strong human data yet, especially in terms of dosing. Um, and I mean, THC works. So, I don't I don't know why a lot of people feel like we need to replace it with a different cannabinoid. It's it's so potent at the CB1 receptor and it's effective at the CB2 receptor, so you get these nice dual mechanisms. I think it would be interesting to study, different terpenes as well. Pinene is one that experientially with pain patients, I find to maybe be really helpful for their pain. That's not sedating. Whereas, I think also probably myrcene is a pain reliever, but it is also sedative. So yeah, I've always wanted to do, some formal prospective terpene trials, and hopefully, who knows, one day it could happen. Um,
That's
but
really
yeah,
interesting that
it just makes it more complex for a clinical trial, when you've got a complex mixture. We don't have good methods for studying complex mixtures, and pretty much everybody's following the pharmaceutical model of, one molecule, one target. But we know people out there in the real world using different chemotypes may get different experiences. So it would be very interesting to find that out.
that is really interesting. That's interesting that you have the lived experience of people with having better experiences or more positive experiences with pinene specifically and myrcene because I have not heard that and but I also don't work with migraine patients, so that's really interesting to
Well,
know.
it wasn't not specifically migraine, but just pain,
Pain.
neuropathic pain where people are using vaporization for rapid effects, and they want to be functional during the day. And, unfortunately, pinene has almost been bred out of most chemotypes. And if you look at the data on the hybridization of the plant, everything's very myrcene dominant. Um, so yeah, those studies are yet to give us more insight into that.
So Kyle has a follow-up question, which is, was the terpene data provided for the material, and were there dominant terpenes and percentages? Michelle is shaking her head no.
No, they provided us with a certificate of analysis, but it was only the cannabinoid content. And
Right.
then
And
I had said earlier, we did not retest it, just probably due to limitations on funding. We'd have to pay even internally at UCSD to have that tested.
something else that Dr. Sexton and I were discussing before was the placebo material that they used was actually the same plant material that had been processed in some way to remove the active cannabinoids. And so I thought that was really interesting because, in theory, it may still contain some of those other phytochemicals that were in the active uh, products.
Yeah, I think Daniel has a question.
Yeah, go ahead, Dan.
Thanks. Thanks. Congratulations on getting it done. It's hard work. Appreciate it. Um, was there any signal from the patients that had auras as to whether or not the period of their visual change was shortened?
Um, I don't know if our data would have captured that.
Yeah, it wasn't in the questionnaire, I don't think.
Yeah, I don't, yeah. I don't, I think that would probably be a separate analysis because, we were first just looking at most bothersome symptoms broadly.
Right.
But probably the data could be mined for that, but that wasn't something that was done for this publication.
The reason I ask is because the spreading depression is usually associated with the aura, not the
Mhm.
pain. And
Right.
it takes about 20 minutes, right, to
Mhm.
have that depolarization spread across. And it would be really cool, I think, to determine if cannabis can shorten or somehow ameliorate that period of spreading depression, because that's also associated with traumatic brain injury and seizures and
Mhm.
things like that. It's not just
Mhm.
migraine.
Right, right.
So, and it's glutamate that is associated with that. So, but anyway, I think this is a great study. I remember Ethan Russo saying on more than one occasion that he had hoped this study could get done,
Yeah, yeah. He was very jealous and wanted to be involved, but we had very limited funding and um, yeah, we were just had our heads down trying to get it done.
Wow.
So
Strong work.
yeah, I can ask Dr. Schuster that question about the aura because he looked at the data a lot and he might have gleaned something about that. Um, so I
Yeah,
can ask, let you
you may
know.
not have had, yeah, there may not have been enough of those particular patients. But in the clinic, we always advise our migraineurs to medicate as soon as possible. And with those patients that do have an aura, not everyone does, but those that do, oftentimes you have a higher success, um, a higher chance of success because they get a warning before the pain comes.
Right. Yeah, and I think that's what we were trying to hit was,
Yeah.
we were looking at aborting, and I'm seeing somebody said something about thought somebody said something about oral. Oh, yeah, Tara asked, have there been edibles included in the study? And the answer is no, because the pharmacokinetic, for the edibles is so long, and we were looking for something rapid that would abort the migraine, not take that long to take effect. So,
Um, I'm not familiar with migraine pain studies. Is the most bothersome symptom, is that something that each person identifies for themselves, or is there like okay, yes. So they are self-reporting.
yeah, because everybody, not everybody gets nausea, or some people get nausea, but they don't vomit, and some people vomit every time, and some people don't get photophobia and they get phonophobia, so I don't think they necessarily had to have all of them, but they did have to, have a classic migraine that has some of those other symptoms with it.
And then this paper is uh, predominantly focused on acute migraine treatment. And in the beginning of your presentation, you discussed that there's like preventative migraine treatment and then acute migraine treatment. Do you think that there is a potential for cannabis to be used in the preventative treatment aspect also? And what are the pharmaceutical drugs that are aiming towards preventative migraine treatment like right now?
Well, the CGRP inhibitors, are basically trying to prevent migraine because if you can keep that CGRP from doing its thing, then, the thesis is you're going to prevent migraine. So, that's really all the rest, everything else out there is abortive. And, there was just that one study that people using cannabis reported that they had a reduction when they were using a combination of inhaled and oral. So I usually tell patients this, if they get sent to me for instruction on trying to abort migraine with cannabis, that, using it orally might also reduce the incidence. So some people might, for instance, use it daily at bedtime. Um, but most people want to be functional during the day, and uh, if they're not having other pain, there may not be any reason that they're wanting to use cannabis across the day.
That makes sense. Looks like Tara has a few more comments. One is, have you included CBN in any studies?
I'm sure CBN was probably in that plant product because it was baked.
And
Uh,
being vaporized
Yeah, the
additionally.
FDA required, well, they just adopted, food standards for how they were going to, make the plant product safe to kill all the organisms, and that was by baking it. I know Mahmoud Al-Soli told me one time, and I've looked and looked for the email, and or maybe he said it to me in person that he told me how long they were baking it and at what temperature, but it's an FDA food regulation. Um, so I'm sure there's CB in there. I was trying to see if I had a certificate of analysis. I'm not seeing it.
And then Tara says, I also have Aura, and the sodium channel seems to be my go-to for quick response. That's when I take the edible. Just thinking edibles in theory could have less variables for study. However, digestion of edibles seems to vary. And
Yeah, the variability for ingested cannabis is huge.
yeah.
Because there's just so many factors involved. Whereas everybody's lungs, if you have healthy functioning lungs, work the same way. And so that pharmacokinetic for inhaled is very standard and predictable, whereas the pharmacokinetic for edibles is just wild. You know,
And it seems like based on some research out there that there's a good chunk of people who can't digest edible or can't feel edibles at all. And so that there's a whole nother wrench into your clinical trial then if you have 20% of people who are unable to feel the effects of edibles.
yeah, we don't know why. So yeah, I'm not really that interested in CBN because, it's a degradation product. It's much lower potency, although, there is interesting research that just come out as a potential candidate for, drug development for Alzheimer's disease. Um, so yeah, that kind of remains to be seen. I think the claims about CBN by the industry are, you know, not well supported by a lot of research, um, but definitely being marketed quite highly. So yeah, if
Um,
you're going to use CBN, you have to use 4 times the amount to potentially get the same effect as THC. So why, again, the question is why?
yeah, that's a great question. I think a lot of times people are looking, the main reasons I see people looking to avoid THC in cases like this where there's a direct benefit is mostly just when children are involved and like for people who have um epilepsy, I know that there's a lot of research indicating that CBD is more effective than THC. Um, but between the two of them, they do a good deal of the work.
Yeah.
Great. If we have any other questions, this would be the time to drop them. But thank you so much, Dr. Sexton, for sharing this. This is like really exciting research, the first paper of its kind and the first clinical trial of its kind. That gives us so much hope that there's going to be more research and more publications like this coming out where we can take this information and directly apply it to people's lives. And that's so exciting.
Yeah, and hopefully we had hoped to do a follow-up study that was a dose ranging trial, but again, funding, and then, when you're a pain specialist and well-known, you've got pharmaceutical companies coming with money for you to do their clinical trials. And, that's a lot easier to do than to go try to find money, especially for cannabis research. So.
Yeah, especially with our current political situation, it doesn't seem like there's a lot of research funding coming through. But I just wanted to offer if you guys ever do another paper like this and you need terpene analysis and you have material to spare, I'm sure that Abstracts would be more than happy to do the analysis just to benefit the research.
Oh, thank you. Yeah,
Mhm.
that's good to know.
Yeah, because we're huge advocates of getting research into the people's hands. And that is also like a huge mission of CANS. So, any way that we can support that, we really appreciate you taking the time to share your research with us.
Well, it was mainly Dr. Schuster's research, and I supported him and did help, especially with filing some of the federal documents that we needed. That was a lot of heavy lifting. Um, but yeah, he really gets the credit because he got the funding and he was the primary investigator, and I was his research associate. So I was happy to be involved.
Well, we're glad to have you and your expertise and everything. So, if you have any other comments or if you have anything else that you want to plug or share, this would be a good time because it lives on our YouTube. But otherwise, thank you so much again.
Yeah, thank you for having me. I have written a book about the endocannabinoid system called Eat, Sleep, Relax, Protect, Forget, an endocannabinoid guide to systems wholeness for women. But a lot in there that men can learn about too. But I have been focused on women's health for a lot of my career. And, the use of cannabis by women has really increased substantially. And we still don't know a lot about health effects for women's health. So that's a real interest of mine. And then I wrote the book just to help educate people about the endocannabinoid system and how it really is a good systems approach to health because it's in every tissue in our body. And so having good endocannabinoid function is a way to promote health.
My gosh, that's so amazing. I will definitely link the book in the show notes below this so people can check it out. And I'm definitely going to go purchase a copy right after this because that's so exciting.
Well, let me send you the link because it's on Amazon, but of course Amazon gets almost all of the money.
Oh, yeah. Send us the link
Unless you
that
want to
you would.
buy, if you buy it on Amazon and leave me a review, I would greatly appreciate that because Amazon will not promote it until you have 50 validated user reviews. So that means you have to have bought the book from Amazon. So my book still doesn't get promoted because I haven't been able to get very many reviews. So if you don't buy it from Amazon and leave a review, it doesn't count.
I
But I
see.
think I did reduce the price on Amazon, which is not good for me, but be good for you.
Well, send me the link that you want to promote, and I'll promote both of them in the show notes so people can have a choice on who they want to do. And they'll see this, so they'll see that you would love reviews, and I'll definitely leave one once I finish it.
All right. And thanks to Kyle for inviting me, and thank you for organizing all of this.
Yeah, absolutely. Thank you guys so much, and please enjoy the rest of your Tuesday and give Dr. Sexton some more love and applause in the comments. Thank you guys.
Thank you.